Okay, so I'm gonna give a brief little session on a new blade that we've just got. That'll be familiar to most folks in the hospital because the GlideScope has had such wide adoption within most health regions, rightly or wrongly. I certainly like our CMAC much better, and I personally am a fan of the regular CMAC blade more so than this blade. But I do actually believe this blade does have applicability sometimes, particularly with very anterior airways. The D blade does give you probably the best view you'll get of the cords with any device. The problem with the D blade is very often you can see the cords and then you can't cannulate them. So I want to talk about how to use this to our best advantage and how to get around some of the difficulties you can have with the D blade itself. Okay, I just want to review one aspect of the D blade that we really need to go over. It is inserted into the mouth differently than any other blade. Generally speaking, we're inserting on the right side, sweeping the tongue to the left. With this shape of blade, it is different in that you still have to insert at a bit of an angle to avoid the teeth, but as soon as you're in, you basically are in the midline of the mouth, not to the right side sweeping the tongue. You're in the midline, displacing the tongue directly away from you, up and away from you. And so it is a little bit different. You're not, again, trying to push from right to left like you are with most scopes. It gives you a very sizable channel to work with, for insertion of the tube into the mouth. But just remember, this scope is meant to be used in the midline as soon as it's basically, again, past the teeth, so you're not going to be hard on the teeth. It's important that you not rock with this. You can generate a ton of force on the teeth with this, so be very careful, just like with any scope, that you're gently sort of rocking away from the teeth. The upper part of this shouldn't be putting pressure on the incisors at all, so be careful about that because it's quite easy to do and you can, again, generate a tremendous amount of force. So just before we get started, I want to review some of the equipment we're going to be using. First thing being, I haven't got the video link to the CMAC because our crew, of course, Murphy's Law would have it, got dispatched the moment we started to do this session, so the video had to go with the helicopter, but that's okay, we don't really need it for this purpose. I'm going to go over a few other things here on the mannequin's chest. So I've got a bougie, which we're going to use in a very atypical way. It is not used the standard way. I'll go over that. Fresh stylet. I've just got an MR7 evac tube, and I've got a syringe that I have attached to the evac tube, and I'll tell you why that is in a moment. So first things first, when you use the D blade, you insert it carefully. It's quite easy to injure the teeth with this because of its hyperangulation. You're going to insert it until you get the best view possible of the cords. You actually look in the mouth until the blade is past sort of the back of the tongue, and then start to look at the video screen, which I would normally have sort of sitting here in front of me. Once that's in and you've got your best view of the cords, the actual best view for passing the tube is not the best view that you will see, because the best view you get with the D blade actually produces a very anterior airway. And so one of the things I've learned over the years, and certainly I've had anesthesia colleagues show me this, is they actually get in, get the best view they can, and then they actually back off a little bit and let the cords relax down, and you actually get a smaller view of the back of the V of the cords than you do when you're in all the way with the scope. So that's tip number one. Tip number one is get in, get the best view you can, and then back up just very slightly, especially if you're having trouble cannulating the cords. That little bit of backup takes some of that acute angle away and flattens it out so that you can pass the tube more easily. Second tip involves preparation of the tube beforehand, which I guess I should have done before even putting it in the mouth, obviously, but it's very, very, very important to know how to bend this properly, and there's a few things different about using the stylet here than with using a stylet on any other airway. First thing being is you want this stylet to be able to go right to the end of the tube. Not coming out, but certainly right at the end. Second thing is, so that's right very, very close to the end, or at the end, as you can see. You actually twist the tube on here so it's actually reverse loaded. The natural curve of the tube wants to go this way with the eyelet pointed in an up position, or not the eyelet, pardon me, the canter of the end of the tube pointed in up position. I actually would advocate loading it backwards, so you're going to bend the tube in a position that is not natural for the tube, and that allows the end of the tube to actually bump against the anterior airway and kind of force it down more easily. You're less likely to get that wedge stuck in the anterior airway if you load it this way, so reverse loading is helpful. Next thing involves where you bend the tube, and you'll see lots of different ways to do this. Some people advocate bending it along the natural curve of the scope itself. I actually find that doesn't help me very much. So my personal best trick, and this works, gosh, very, very nicely, is I actually bend the tube right at the balloon in a very acute angle, which is actually a little bit more than 90 degrees. So it's about 100, 105 degrees even. So it's a very, very acute angled tube with the stylet, again, even protruding slightly, reverse loaded. You can bend that if you like to help, and that actually allows you to get the tube into the position of actually, as soon as you put it in the mouth, being in the correct position for the airway. So I can get in there now. You actually load this in sideways in the mouth. Sorry, I put that in wrong in the beginning. Sideways, as soon as you make the back of the tongue, you rotate it in a position, and actually that tube is basically sitting right in the opening of the cords. Now, as I advance that, you know, it's best actually to have someone, a helper in this circumstance, and would pull the stylet for me. So I'm going to do that. I'm going to help her here right now. So I would pull that out as I advance it, like you would with the real tube. The important part about that is you actually have to stabilize the tube, and I'm going to let go of the scope to do this. As you advance it, you basically really have to hold this tight, or it's going to pull the whole tube out. And as you advance it, then it'll go into the airway very, very nicely. If you don't hold it tight because of that hyperacute angle, as you go to pull out the stylet, it'll actually back the tube out of the foreshed of the cords, and you won't get it in. Now, sometimes you'll find, and this is really common, this is part of the reason I actually was a giant non-fan of this thing when it first came out, is you get this great view of the cords, you pass the tube, whether this is hyperacutely angulated or not, and what happens is it sits just behind the cords. So you've got your hockey stick, or if you've chosen to load it another way, and again, other people will advocate bending this essentially to match the shape of the blade exactly. I don't find that as useful personally, but again, you'll find docs that also believe in that method. So you're basically making the shape of this match the scope exactly. There's method to that madness. If the scope is in a position with that angle, theoretically that should follow the scope in very, very nicely. I just find that doesn't work as well for me personally, so I do prefer the method that I talked about before, which is again reverse loading the tube and then hyperacutely angulating right at the balloon. But what you'll sometimes find is you'll go to do that, and you've got the back of the cords, sort of the ledge at the back of the cords, and you just keep pounding this into that ledge. It won't quite get over the ledge. It's just sort of sitting there like this, and you can't get it over the ledge here, and the cords are anterior to that. And so one of the ways that you can deal with that, I was shown this by one of the ICU docs at the Peter Lockheed Hospital. Great little trick is basically you've got the scope in the mouth, you've got the best view that you can, you've backed off a little bit to make the angle a little bit less. You get the tube in, again loading it sideways in the mouth, back to the tongue, and then you rotate it. And then you're just sitting there and you can't quite get over that ledge. Is again, I need a helper here to do this, but essentially as I advance this whole setup, you have someone below the balloon as you're advancing the kit, which uses the balloon of the tube actually to push it up and over the ledge. And then once you're sitting in place, you deflate the balloon, of course, before you cannulate the cords. You're sitting now in the right location. You stabilize that tube very, very well, remove the stylet, and which is hard. My hands are slippery now, so because of the lubricant we're using in the mannequin here, but you know, that would come out normally if my hands weren't so greasy, so apologies, but I don't have anything that's going to help me with that right this minute. You pull the stylet out and then advance the tube, and then you blow up the tube again. So apologies, I can't really demonstrate that with my hands like this, but the bottom line is blow the balloon to get it over the ledge. Once you're sitting right in front of the cords, go ahead and let the balloon down, pull the stylet, advance it, and you're golden. Works very, very, very nicely. Final thing is occasionally what happens is you'll get in, I'm going to have to remove this now, just for demonstration purposes, I got to get this out. And you'll be sitting, stylet out, and it still is bumping against the anterior area, again because of the hyperacute angulation of the D blade. And this is a nice trick that I came up with that I really like to help get around that. And so the cord now is sitting, or the tube, pardon me, is sitting just before the cords, but sort of pounding against the anterior wall of the trachea because of the hyperacute angle that I put it in, and you can't get it to tip down and go in. And the way that I've dealt with that is to use the bougie actually upside down through the cords, or through the tube, pardon me. It'll sort of bump up generally. You back the tube out very slightly. The bougie kind of bumps against the anterior area, then down and in. You will not feel the usual tick, 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 tick along the trachea because the tube just takes away that tactile feeling. If you use it with this end, I found sometimes that seems to hang up as well, so I actually usually turn it upside down. You could try this with that also facing down, but that'll also sometimes force it into the back part of the trachea and not through the cord. So I've just found going with the straight section in works nicely. That goes in until you meet the carina, which is what I've got right there. You stabilize it, and basically at that point, you back up a little bit, and then the tube will go in just like a Seldinger technique. So you back up to get the tube impacted off the impacted, sort of location it is against the anterior trachea, and then it just glides down over the bougie, and then you remove the bougie. So it's an atypical use of the bougie. You cannot, in my experience, use the bougie with this blade like we would with other blades. The angle is too acute, and I have never been successful personally. I'm sure somebody out there has been, but I haven't been in getting the bougie to make the angle. If we had a trigger bougie or something where we could manipulate the end and get it very acute, that might work. But in my experience, this is too flexible and generally ends up behind the cords and not through the cords when you try to use it with this blade directly. So that doesn't work as well. Final trick, and this goes for all things CMAC, is your helper when you're having difficulty, again, making the angle. The airway is very anterior. You've backed up a little bit. That hasn't helped. You've tried the balloon trick to get it over the edge. That hasn't helped. You've tried the bougie trick, and it's not quite cannulating through the tube for any number of different reasons. You just can't get cannulated through the cords. Get your helper to pay attention to what's going on in the video screen, and get them to directly manipulate the airway to try and give you a less anterior airway. And they can see as well as you can if you're having trouble cannulating and the tube's going off to one side or the other. Sometimes subtle little rotations, 5 or 10 degrees of the tube as you're trying to pass it, can also help to kind of get it to finally flick over the ledge and line up with the cords. And other times, again, your helper's direct energy manipulation in conjunction with you rotating, advancing, the combo helps you to get through it. And then there's one final unique circumstance I've had now in 2 different extremely difficult airway scenarios, the toughest airways I've had in years, where I've used a combination of the D-blade with 2 people. This is 2 people doing it now. One person gently on the blade, getting the best view of the cords that you can, getting soft tissue out of the way, and then a second person with a fiber optic bronchoscope who's sliding in beside the D-blade and then cannulating the cords with a fiber optic scope with a endotracheal tube over the scope. That's not likely something obviously AMC are going to do, but you may be called to assist with a physician in a rural hospital or one of the TPs who's brought a bronchoscope with them for whatever reason. And this is a beautiful technique to get into airways that you just cannot get through any other way. I've used it twice now when both myself and a very seasoned anesthetist were absolutely unable to cannulate the cords by any other means. And then with a fiber optic scope, me holding this and getting things out of the way, making as much room as I can, the anesthetist was able to get in with a scope and make that cannulation. So those are the best tips I can give you for use of the D-blade. Again, not my go-to device from the outset. I would use this only in circumstances when I couldn't get it with the regular blade. But I do think it has advantages because, again, sometimes this shape of blade will allow you to see cords that you just cannot see through any other means. This will undoubtedly give you the best view you will ever see of the cords. Problem being, of course, seeing and cannulating are not the same, and that's where you need to go to all of these other tricks that I've just talked about. Okay, so I just want to review removing the stylet again one more time. I've got some unbelievably talented help here now. Trent's going to give me a hand. So just review one more time how to load the stylet properly. So again, properly load it so that the stylet is right at the end of the tube. I've twisted the tube so that it's going to be reverse loaded. Again, the curve is going to be opposite from normal, for the reasons I've identified, to keep that cantered end of the tube in a position where it's best able to bounce off the anterior airway and down through the cords. Hold the tube right at the balloon itself and bend it to, again, about 95, 100 degrees, something like that. Again, that will make it quite hard to get out. So I've got my tube bent the way I like. Always load it with the 10cc syringe on it so you can blow the balloon if you need to, for the reasons I've already talked about. Got my scope. I'm going to put the scope in again. Again, look at the patient until the scope gently passes the end of the tongue, and then you're going to look at the video screen, which I would normally have here or here where people could see it. The tube is inserted sideways into the mouth. It's a little bit of a trick to get it by, but as soon as you get past the back of the tongue, you rotate it to the midline. Blade is in the midline, unlike a regular scope, which is swept from the right side of the mouth. This is inserted in the midline. And then once you're in place, you get the best view you can watching on the video screen. The end of that tube should be just in front of the cords now, but not through the cords because it's too anterior. And then you stabilize it. Now it's sitting above the cord. I'm going to get Trent to pull that out. It's hard. And then advance, and then of course blow the balloon. Next trick would be, we'll just review this one more time. I'm going to load this in again for those circumstances where it absolutely will not go above the ridge just before the cords. So reverse loading, right to the end of the tube, bent right at the balloon, 100, 105 degrees, anywhere in that range, 95 to 105. I've waffled a bit on that, but that's basically the way I like it. I haven't got a protractor here. I'm going to say that's probably 95 to 100 degrees in that range. So if we get into a circumstance, again, I'm going to insert this in the midline very gently. I usually have to twist a little bit to get it in, then right back to the midline. Get the best view you can, and then come back just a little bit to let the tube or the cords come a little bit less anterior. This is inserted sideways until you gently make the corner, and then rotate it to the midline. Now if this were sitting in a circumstance where, again, it just wasn't quite getting over the ledge, I'm going to have you blow the balloon up when I ask you to. So basically I'm going to gently advance, blow the balloon please. As I do that, the balloon is pushed the end up and over the ridge. Now you can bring that down, suck all that back out. Okay, tube is now sitting in a position I want it to be. I'm going to ask you to pull that. You really got to stabilize this so you don't lose your position. And then we advance, blow up the balloon again, which I will do with my slippery hands here. And we're good to go. Thanks.